Well, welcome all of you to the September 9th, 2020 regular meeting of the Washington Hospital Healthcare District Board of Directors. To comply with the Alameda County's orders as revised on June 18, 2020, to slow the spread of COVID-19 and reduce the rate of transmission by sheltering at home and continued social distancing. This meeting will be conducted by Zoom. I ask that you all please mute your system until such time as you need to speak. Governor Newsom's Executive Order N-2920 explicitly waives the Brown Act provision that requires the physical presence of members, the clerk, or of the public as a condition of participation in or quorum for a public meeting. We continue to comply with the Brown Act and providing dial-in information in order to provide the public the opportunity to attend the meeting. Public notice for this meeting, including dial information, has been posted appropriately on our website. We are recording tonight's regular session of the board meeting. It will be posted on our website for future viewing. Members of the public are invited to speak during our oral communications. When prompted, please state your name for the record, then proceed with your statement. Not to exceed 3 minutes on issues or concerns not on the agenda and within the matter of jurisdiction of the board. And at this time, it's early, but I'm going to ask if there are any members of the public attending this meeting who would like to speak. Hearing none, we will then continue with the agenda. Thank you. Please, Dee, would you please take the roll?
Director Wallace?
Present.
Director Nicholson?
Present.
Director Epen?
Present.
Director Yee?
Present.
Director Stewart?
I'm sorry, present, I was muted.
Okay, well, thank you. Did I hear, is Dr. Epen here?
Yes, he is.
Oh, okay. All right. Well, thank you all. Thank all of you. So that motion passes. So could I have a motion for the approval of the consent calendar? So let me, before we get into that, let me, please bear with me. Thank you. I can't see that well anymore, I guess. Okay. We're now going to consider consent calendar. The consent calendar consists of those agenda items that the board will approve with one motion unless either a member of the board or a member of the public requests to remove an agenda item from the consent calendar. If any items are removed from the consent calendar, the board will take action on the removed item later in the meeting until the action item heading on the agenda. Does anyone on the board want to remove an agenda item from the consent calendar? Okay, then does any member of the public want to remove an agenda item from the consent calendar? Okay, may I have a motion to approve the consent calendar, items A through E?
Mr. President, in accordance with district law, policies, and procedures, I move that the Board of Directors approve the consent calendar, items A through E.
Thank you, Director Stewart. Do I have a second?
Second.
Okay, Dee, would you please take the vote?
Director Wallace,
Aye?
Director Nicholson,
Aye.
Director Yee,
Aye.
Director Epen,
Aye.
Director Stewart.
Aye.
Okay, thank you all. That motion's approved. Okay, we'll now move to the communications. Are there any oral communications? I assume there aren't any because we didn't hear any earlier. Any written communications, Dee?
No, there are none.
All right, then we're going to move to the presentation. Kimberly, please.
Yes, thank you. Tonight, for the presentation, we have two pieces. The first is a video that really that shows a timeline of several of and also describes the many ways that Washington Hospital Healthcare System has prepared to meet the needs of our patients, our staff, and our physicians, and how really talking about the importance of safety and not to delay care because of all the initiatives that we have been putting in place during this pandemic. Following the short video, we have Dr. Diane Martin. She's actually going to be speaking twice tonight to the board, and she is going to be making some additional remarks, and she's also going to be speaking later on about the 2020 Influenza Prevention Program. But I'm just going to take a minute and introduce her right now. And I know she is known to many of us. She became a member of the Washington Hospital's medical staff in 1984 and served as chair of the Department of Medicine from 1993 through 1995 and has performed many leadership roles at Washington Hospital. She attended the medical school in Charleston, South Carolina, after which she completed her internship and residency at the University of Kentucky School of Medicine. She received a fellowship in infectious diseases at the University of Davis School of Medicine. Dr. Martin serves on the board of directors of Life Elder Care, and she is a member of Washington Township Medical Foundation. I also just want to say that Dr. Martin has been instrumental in this whole pandemic. She's a physician leader. She has spent countless hours advising and guiding us through the many novel issues we have faced. And she truly embodies the patient-first ethic. And her expertise has been invaluable in our success in terms of keeping patients, staff, and physicians safe. And I very much have valued her expertise during this time. So with that, why don't we start, if Shri, if you can show the video, and then Dr. Martin can provide some remarks.
In January, news of the novel coronavirus began to break. Soon, this included cases in California. In February, members of a family visiting from China were seen in the emergency department of Washington Hospital and were determined to be positive for the coronavirus, which later became known as COVID-19. Immediately, a multidisciplinary team at Washington Hospital started to develop a plan to care for these patients while ensuring the safety of all patients, physicians, and staff members. This team has continued to meet on a regular basis, often daily. Following CDC guidelines, we began with signage at all entrances, asking screening questions, and advising visitors and staff members to alert staff of any symptoms. Soon, this developed into screeners who took each person's temperature, asked screening questions, made sure everyone used hand sanitizer, and handed out masks to everyone entering the building. Throughout our campus and clinics, we established a universal masking policy for everyone entering the area. Entry restrictions on all persons not directly involved with providing health care, including volunteers, students, and visitors, resulted in fewer people at the facility, reducing potential exposure. Additionally, during the shelter-in-place order, all elective surgeries were canceled or rescheduled, as well as reduced hours for outpatient services. This also reduced the potential for exposure. In order to more quickly see patients suspected with COVID-19 and to reduce possible exposure in our emergency department, the Rapid Screening and Treatment Unit, also called the RSTU, was installed in an area adjacent to the pavilion. To meet the demands of testing, we added our diagnostic capabilities, purchasing equipment from BioFire. This allowed us to perform in-house testing and test all inpatients and pre-procedure patients. Understanding the importance of informing community members about this virus, we developed pages on our intranet website. We also published several articles in the local newspaper and on social media on COVID-19 and the precautions Washington Hospital has been taking to keep all patients safe. We developed an internal website for our physicians and staff members, offering information and resources, including daily updates, self-care resources, links to CDC and Alameda County websites, and instructional videos. We produced 2 informative videos for community members and staff featuring infectious disease specialist Dr. Diane Martin and emergency department physician Dr. Kadir Halimi. Additionally, we provided staff with instructional videos on how to properly change into and out of personal protective equipment, PPE. These videos were shared with skilled nursing facilities and other congregate living facilities with whom we have been working closely to help contain outbreaks. For the safety of our staff and community members, we changed the format of our education seminars from in-person to Facebook Live presentations. In addition to universal face masking, anyone who has contact with patients wears a face shield. Despite challenges to our supply chain, our clinical staff have personal protective equipment that includes the appropriate masks for their type of work, face shields, gloves, shoe coverings, and both disposable and reusable gowns. Members of our leadership team review inventory on a daily basis to ensure we have sufficient supplies to keep our patients, staff members, and physicians safe. Additional secured equipment has ranged from ventilators to iPads, which help patients interact with family members. In order to safely accommodate all our COVID patients, we created additional negative air pressure rooms which prevent cross-contamination with other patients and rooms. Many rooms have a changing area where caregivers safely change into and out of protective equipment before and after entering rooms. In addition to planning for immediate patient care, the multidisciplinary team has created a plan in the event of a patient surge. And finally, to encourage community members to refrain from delaying their healthcare needs, we launched a campaign letting people know it is safe to seek medical attention, safer than to delay care. Ensuring the safety of our healthcare providers ensures that we are prepared to continue to care for our community members.
Well, that was really pretty good. Now, how do we intend to use that? I may have missed that.
Yeah, we are going to be putting it out on various, we'll put it up on the website. We'll be sharing it with other organizations and through social media. So we'll have links to it so that the community does sort of understand all the work that we have been doing and really the focus on ensuring everyone's safety. I don't know, Dr. Martin, if you have any comments that you'd like to make on the video? I can unmute you. There you go.
I think I'm unmuted now.
Yeah.
Okay. So I'd like to really commend that the hospital has been proactive from the very start to make sure that our patients and the staff at all levels were provided safety measures so that we could take care of patients whenever they were coming in. So most of them were coming in through the emergency room. And as people know, our emergency room with the new Morris Hyman Pavilion is state of the art. They have individual rooms with glass doors so that we can monitor patients carefully. We have the latest equipment so we can provide excellent care, outstanding care for all of our community members. So with that, we put a lot of safety measures in. We worked with all levels of our staff, from the physicians to executive staff, including environmental staff, so that everybody felt protected and covered, and that they had access to adequate PPE, which is personal protective equipment. It's at times been tough to make sure that we have adequate supplies, but we have maintained those throughout these last 6 months, which has been difficult on a lot of levels, but we've been able to maintain that. We've also coordinated well with Alameda County Public Health, California Public Health, and CDC to make sure that what we are doing is consistent with the guidelines from the national level as well as the county and state level. So we have been trying to do that, as well as update our teams, whether it's environmental teams or critical care teams or physician teams, so that they are updated day to day. And as we well know, this has evolved and changed from the very beginning all the way till now. Things are totally different than when we first started, but we're moving through that. We're keeping people educated, and we're making sure that we're updated with the latest that we have available. So we've been very proactive in taking care of our staff and our patients. So we'd really like to reach out to patients to tell them, you are very safe here. This is probably the safest place to be because of all the cleaning and all the measures that we have put in place. So I think people should no longer fear coming to the hospital, to the emergency room. We've maintained our ability to see patients on a very timely basis and make sure that they go through the process very timely and that they're discharged timely. We work through that every day, not that we don't have ups and downs, but we work through it. I think we're providing the best care. We do sometimes coordinate with Kaiser, Stanford, UCSF to see where we can share collegial advice and stuff. So we do maintain a communication with them, but I think we're equal to those. As a community hospital, we have outstanding staff and outstanding leadership. I think patients should not worry about coming here. We're going to provide the best care if you are our mom or our dad or our brother or sister, just like anybody else.
Thank you, Dr. Martin.
Are there any questions or comments from any board members? I just, you know, what can I say? I mean, I think it's exemplary what our staff has been doing for the community. I echo what all that you've said, Dr. Martin, and I think the video speaks for itself. And I just hope we can get it distributed and understood. So thank you. All right, so then we're going to move on to the reports section of the agenda. First is going to be the lean report.
Yeah, so this evening we have Donald Pipkin, our Chief of Strategic Development, with us, and I know it's long overdue. He's recognition of 2 individuals who have become lean certified. So I'm going to pass it on to Donald to give the lean leader certification update.
Great, thanks, Kimberly, and thanks for having me tonight. I have the privilege of presenting our latest recipients of the lean certification. But before I start this presentation, I just wanted to give some background of what the Kaizen Promotion Office or Lean Department has been doing over the last 6 months or so. Given the impact of COVID, the Lean Office has been assisting with our response to the pandemic. For example, we have worked with our medical foundation to develop standard work and processes for virtual telehealth visits in clinics throughout the healthcare system. In addition, the Lean Office has been working with inpatient and outpatient departments to incorporate key operational and quality metrics related to COVID, as well as the overall quality targets and strategy for the healthcare system into our continuous process improvement efforts. Over the next several months, since we are still under the impact of COVID and the pandemic, the Lean Office will continue to work with departments throughout the healthcare system to ensure lean methodologies are applied to our continued response, not only to COVID, but as well as other operational and strategic goals through the lean daily management system. So I just wanted to give that background before we got into this presentation. So with that, we will get in, and I have the pleasure of presenting our latest recipients of Lean Leader certification. So on the next slide, really the purpose of this certification is to promote and lead Kaizen or continuous process improvement activities in the institution. So these recipients have gone through a number of training activities, which we will describe, but really the key is also to train others throughout the healthcare system to continue to promote these improvement efforts at the front line with managers and throughout all levels of the organization. It's really the goal is to make lean the philosophy and methodology for all improvement activities. Next slide, thank you. So lean certification training is not a short process. It takes about 12 to 18 months. It does require proficiency in lean concepts and tools throughout that process. And at every step of the process, candidates are evaluated for successful performance in each step. Next slide, please. So the requirements include 8 full days of didactic classroom education, previously taught by Rona Consulting Group. Now this is actually taught by the Lean or Kaizen Promotion Office. So this is all in-house now in terms of the training for our staff. Each candidate has to participate in what we call a value stream mapping workshop. And essentially this is where we look at a process from beginning to end and map all processes within that full continuum. And they have to participate in one of those, and then also a Kaizen workshop or a lean improvement workshop. So really these are focused on a specific topic that was developed within that value stream workshop that the candidates then need to participate in for improvement efforts. In addition to that, the candidates also need to act as what we call a team lead or workshop lead, and they need to perform both roles in these workshops, and they have different roles in those 5-day workshops in order to coordinate the improvement efforts with the multidisciplinary team. Next slide, please. So today, typically we would love to present this in person. I know given the circumstances, we're presenting it via Zoom, but I know we have Mintu Denon, who is our pharmacy director, and Sandra Bemis, who's the controller for the healthcare system, on the Zoom call today. And I would just want to congratulate them on their receipt of certification for this process. And we have a couple pictures here to show the board and the team of them receiving their certificate. So next slide, please. And there's Mintu receiving her certificate. And again, we'd love to present this in person. Maybe in the future we'll do that. But thank you, Mintu, for all your hard work in obtaining the certification. And then next slide, Sandra as well. So I just want to congratulate them both. It's a lot of hard work and effort, and this really, these are the leaders of this organization that will help to continue our development of lean improvement efforts and teaching and training and coaching throughout the healthcare system. And I just want to congratulate them. I wish we could all do it in person. I'm sure we all do, but otherwise, I just want to congratulate them for accomplishing this certification.
Well, thank you. Don, any board members have any comments? Or I want to congratulate both of the recipients, and I love the progress that you're making with Lean, and just keep it up. So thank you.
Thanks, we appreciate it.
Sure. All right, well, then we're going to go back to the quality report. Kimberly?
Yes, we have Dr. Diane Martin, and she is going to talk about another very important topic, and that's the 2020 Influenza Prevention Program. So we'll just bring up her slides. Okay. All right, Dr. Martin.
Am I muted? Am I?
You're.
Nope, we can hear you.
You can hear me?
Yes.
Okay. All right. So somebody's got to advance slides. Yes.
Yes.
Okay. All right. So this is talking about the 2020 2021 influenza, and also because of the obvious pandemic, the effects that that might have on our influenza season and how we want to proceed. So next slide. So we obviously are not totally clear how the impact of the pandemic will have on the upcoming influenza season, but we're quite hopeful that that will be less of an effect because of the measures already in place to reduce the COVID-19. So between using universal masking and restriction of visitors in the hospital and social distancing and encouraging people to wash their hands, these are also measures that greatly influence and reduce the effect of the influenza. We're quite certain that the influenza viruses will continue throughout the circulation of the SARS, the COVID virus, and people may actually be co-infected with both. So it'll be a bit of a challenge when patients are seen either in the urgent care clinic, the offices, or even the emergency room for physicians and healthcare providers to be aware that they may need to look for both of these. The hospital itself has put in testing that will include both the influenza A and B, the respiratory syncytial virus, which we sometimes see, as well as the COVID-19 virus. Next slide. So both of these viruses are very contagious respiratory viruses. They are separate. They are both actually coronaviruses, but the COVID-19 is quite separate from the influenza virus. And the picture that we see in these, there is again some overlap, but some distinction between the two. So commonly both will have a fever or feeling somewhat feverish, warm, overheated chills. Both have cough, both have shortness of breath or difficulty breathing. Both have fatigue, sore throat, runny nose, stuffy nose, muscle aches, body aches, headaches. And some people may have some nausea and vomiting, diarrhea, but we think this is probably a little more common in children than it is in adults. Next slide. So both of these viruses are spread by droplets, such as when somebody is coughing or sneezing, the droplets are then aerosolized, so they are communicated through the air. People can also be infected by touching an object or a surface that has the influenza or the COVID virus, the SARS virus. And then when they touch that surface that might have the virus, then touch their mouth, eyes, or nose. So that's again why we strongly encourage people to wash their hands. Both are spread by people who can have the virus before they actually start showing symptoms or may have very mild symptoms. So a lot of times you can't always tell somebody is infectious just by how they're looking or feeling or even checking a fever. Both have complications associated with them, including bacterial infections such as pneumonia, sepsis, respiratory failure, and that they might need supplemental oxygen, or some might even need to be on a ventilator. Some can have neuromuscular complications where they get generalized weakness, lung complications so that they may have difficulty breathing because it takes over the airspace and you don't exchange oxygen as well. We have seen cardiac complications in both, obviously a little bit more in the COVID than the influenza. Both obviously can need hospitalization and mortality. So the hospital and our staff are very well aware of this. We've been planning for both of these for many months to come. So I think both our ER, our urgent care, and our physician staff are very well aware of this and know to check for both when we see patients that are coming in with respiratory symptoms. Next slide. So what is a flu shot? So as much as we would like to have, and I could communicate to you about a COVID shot, we're just going to talk flu shot. So flu shots enable the body to develop antibodies that provide protection against the influenza virus. And we look at different viruses each year to see which one is most likely to be the virus that's circulating at the time that we see most of the virus. So on the East Coast, we see a little more towards the December timeframe. For California, we may see a little more of a January timeframe. So currently, they're in the current vaccine that's being provided by Washington Hospital and the urgent care clinics and the emergency room. There are 4 strains in this vaccine. 2 are A strains and 2 are the B strains. Next slide. So the Centers for Disease Control recommends that we do annual flu shots for anyone over 6 months and older, as this is extremely important in protection against influenza. We want to especially vaccinate our essential workers, which are healthcare personnel, including those in nursing homes, long-term care facilities, pharmacy staff, and other critical infrastructure workforce, such as our environmental services people. We need to make sure that they stay safe and healthy. We especially like to target people who have other severe illnesses from COVID so that they would be an increased risk for getting both viruses. So these are adults 65 and older, residents of a skilled nursing facility or a congregate living facility, individuals who are immunocompromised, such as diabetes, cancer patients, other racial and ethnic minority groups are also disproportionately affected by COVID-19. So we want to make sure that we're targeting both of those to provide protection through the influenza vaccine. There are also persons at very high risk for influenza complications, which would include infants and very young children, children who have neurologic complications, pregnant women, adults 65 and older, and other persons who have other underlying medical conditions, diabetes, influenza, emphysema. Other high-risk individuals should not get the vaccine who have Guillain-Barré or who have had life-threatening allergies to the flu vaccine. Next slide. So how does the flu shot work? So when you get the flu shot, you have a very good chance, 50% or better, of getting seriously ill than an unvaccinated person. So it does not provide 100% protection, but certainly significant protection against somebody who does not get vaccinated. So the question is, do I need the vaccine every year? And the answer is yes, because the virus changes yearly, and we also change the vaccine to target those viruses which we think are most likely to be the cause of the influenza infection every year. When should I get vaccinated? Usually we try to target by late September, early October, but even if you're not able to get this, say like you have another respiratory illness or traveling so that you can't get the vaccine, you can get it at any time. It takes about 2 weeks to generate an immune response. So that's why we want to target in the fall, because we're anticipating that we'll start seeing influenza probably in January for California. Next slide. So people always ask whether or not the vaccine can give you the flu, and the answer is no. Although there is an activated virus in the vaccine, there's no live virus in it. You may still get symptoms because what it's doing is upgrading your immune system. People may mistake those symptoms for influenza. So the flu shots currently have two ways: inactivated virus or a recombinant virus, which is more, we call attenuated or modified virus. So when you get the flu shot, you may have soreness at the injection site, which is again shows that your body's beginning to react to the vaccine and begin to make immunity or antibodies. Very rarely will this last more than about 24 to 48 hours. So sometimes it can go longer than that, but that's fairly rare. You can always take Tylenol or more fluids or just rest, and that will help ameliorate some of those symptoms. And obviously these are way less severe than if you got the actual influenza, might be very sick or even be hospitalized. Next slide. So Washington Hospital is very proactive, very patient first ethic to make sure that we take care of both of our staff, but also for the patients in our district. So we want to make sure that they get education and information, and that they know that safety is our top priority. We've had a little bit of experience already when we were doing planning for Ebola and the H1N1 virus, which was several years ago. So we feel like this gives us a good background for planning and trying to prevent effects from the COVID-19. And we have multiple safety and control measures, which will be in the next slide. So we do screening for anyone who comes into the facility, whether they're coming in for the lab, they're coming in for x-ray, they're coming into urgent care, they're coming into our ER, or they're coming in for doctor appointments. We do immediate isolation of symptomatic and high-risk patients that are coming into any of our facilities. We also mandate universal masking for everyone, including patients and anyone coming into the facility. And we provide those masks. We also think that the masks that we use are probably a bit higher grade than some of the masks that people make for themselves. And that is probably okay for community, but we want the highest grade for anyone coming into our facility, which includes our doctors, our patients, our staff. We have also restricted visitors. We've also restricted visitors because we're concerned about somebody who might not be aware that they have infection and coming into the facility. So even though they may be well-meaning, we are restricting visitors. There are some exceptions to the visitor policy, and you can see that on our intranet. All of our elective surgeries have mandatory COVID testing. So anybody coming in for an elective surgery must have COVID testing, and it must be done within 3 to 4 days prior to the procedure. And this also includes other procedures, not just surgery. So anytime we're doing stress testing, anytime we're doing colonoscopy, anytime we're doing endoscopy. So even though you might think surgery is like taking my appendix out, it's multiple things that we are covering. All of our admitted patients coming through the ER or urgent care are tested for COVID. We are very careful that we have a very fast turnaround time, about 2 hours for getting most of these tests back. So we can appropriately place patients who are COVID negative away from patients who are COVID positive. And you may be aware we have certain units that are designated to specifically address the needs of the COVID patients. We're also in communication with both the local skilled nursing facilities and the public health department to make sure that we are letting them know what we're doing, and they're keeping us updated with any of the latest guidelines or changes. The SNFs in general, skilled nursing facilities in general, have been very appreciative of our outreach. So Dr. Achanta and Wendy Lamb have been reaching out with them. You saw the educational video that was provided. We've also been very instrumental early on in making sure that they had adequate PPE, personal protective equipment, whether through our stockpiling or through their own avenues of getting it. But this protects our local community as well as patients who would be coming into our facility were they to get sick, and we make sure that they're well taken care of. Next slide. So we want to adhere to any kind of respiratory hygiene, cough etiquette, hand hygiene. So we're wearing masks. We want to make sure that if you're coughing, you probably need to go home unless it's an emergency, and we'll take very good care of you. We do physical distancing, which was at least 6 feet between patients or people coming into the facility. We also do this when all of us are coming in the facility. When I come to the hospital every morning making rounds, I basically have to stand 6 feet back from the person ahead of me, get my temperature checked, wash my hands, and put on a mask. We are also increasing the frequency of surface decontamination and environmental cleaning throughout our facility. So the environmental services have really stepped up. And the other thing we've been really active about is making sure that we have enough of the cleaning materials that we need. We are maintaining a very consistent supply of personal protective equipment. We try to stay ahead of what we anticipate our need will be. And we're also following national standards for healthcare worker safety. Next slide. So in terms of response planning for influenza, we are screening, vaccinating all eligible inpatients. And you'll see in the next slide how successful we have been with that over the last several years. The flu vaccine itself is available 7 days a week at our urgent care, and you can go on the intranet and check their hours. We require 100% of our healthcare workers to have vaccine, proof of vaccine, or if it's declined, they again will stay with masking as per Alameda County guidelines. We also do preventative measures, including universal masking and eye shields, which we're doing, which includes the eye protection policy. We do regular evaluation analysis of our results on an annual basis for employee vaccination rates. We do quarterly evaluation of patient vaccination rates during the flu season. The flu season is dictated in part, CDC has one guideline, we go more by Alameda County. And the emergency room is also on high alert for any influenza-like illness to make sure that those patients are taken care of appropriately. Next slide. So you can see here on our inpatient influenza, so these are patients that are admitted to our hospital. So we started with the 2016 year monitoring this at 96%, and we're at 99% for the last season, and we're hoping to match that or get better for this season. So this way we make sure that the patients are protected in terms of making sure that they stay healthy, and also in terms of transmitting virus to the healthcare workers in our facility, and eventually when the patients go home to their families. Next slide. So you can see here the guidelines for Alameda County. They want at least 87% of influenza vaccine. The Healthy People 2020 benchmark was at 90%. And for Washington Hospital, we have been improving this gradually between 92 to 91%. 100% of our hospital employees, including physicians and staff, are offered influenza vaccine, and this is at no charge to them. So we feel this strongly that we want to make this very available. We have flu clinic options available to the physicians and staff. We have clinic times that are available, and also a little bit later in the season, we have roving carts that will go through providing influenza vaccines to all of our employees and staff. Next slide. So what can you do? One, wash your hands. And we want to make sure you wash your hands well with either soap and water or alcohol gel. Try to cover your mouth while sneezing. Preferably sneeze into your elbow rather than into your hand, but still wash hands regularly. Social distancing will work both for influenza and for COVID-19. The cloth mask for people in the community, and we use the other masks, the regulated ones, while we're in the hospital. And again, if you suspect that you have influenza or COVID, or you're not sure whether it's either one, please come let us check you. Call the urgent care, call the ER, call your physician, but get checked. The other thing that's very important is to get the flu shot every year. I think there's one more slide. Okay, so where can you get the flu shot? So again, the Washington Urgent Care has walk-in clinics Monday through Sunday, 11 to 4. The Danielson Clinic, which is in Newark, has them on Fridays at this point. We also are providing drive-through locations. So if you don't want to get too close to anybody, come to our drive-in. So 2 of them will be at the Washington West, which is just on the side of the building where the urgent care clinic is, and that's on 912 and 926. The orthopedic parking lot, which is just off of Stivers, will have it on 919, and at Nakamura and the pediatric clinic on 103. Take questions.
Yeah, Diane, this is Bill Nicholson. I have 2 questions. My first question has to do with the folks who are over 65. Can you talk about the relative benefit of receiving the high dose vaccine for that age group compared to the standard dose vaccine?
So there is a standard dose vaccine, which is a trivalent. The one that the hospital has made available is the quad. And for over 65, that's an extremely effective vaccine. There is an attenuated vaccine that's called the high dose, which is available, I think, through some of the pharmacies. But the quad that we have available is extremely effective for the 65 and older, including those that are immunocompromised, like a diabetic, a patient with emphysema or cancer patients. It's extremely effective.
Thank you. My second question has to do with the nasal spray vaccine. I believe it's called Flu Mist was the name. Is that still available? And what are the current recommendations for either the pediatric age group or the older folks who are needle shy?
So the CDC came out with recommendations that flu vaccine did not seem to be as effective. So initially it was for pediatrics just for ease of administration, but they've recommended that anybody, if they can, still get the standard injection vaccine. The flu mist is still available, but would be for very restricted indications. So I would say, if at all possible, get the standard quad that we're providing and the injection vaccine.
Thank you.
Okay, well, thank you, Dr. Martin. Thank you.
Thank you.
All right. All right, so then, Kimberly, we're going to then move on. Go ahead.
Yes, now we will have the July finance report. Chris Henry, our Vice President and Chief Financial Officer.
Okay, and we'll jump right into our acute inpatient statistics. Average daily census for the month was much higher than budget, 18.6 above budget at 158 for July. Admissions were below budget by 40 at 833, but our patient days were 576 above budget at 4,898. And as you can see below, that equates to a longer average length of stay. Average length of stay was 0.7 higher than budget at 5.65 days. Our outpatient observation equivalent days for the month were 11 above budget at 184. And as we move into utilization, case mix index is an indicator of that long length of stay at 1.615, which is one of the higher numbers we've seen in a long time for case mix index. And I think it's an indication not only of the severity of the COVID patients that we saw in July, but also the fact that people are waiting a long time to come to the hospital. And again, we want to encourage people that if they're feeling ill and they feel like they need emergency room services, to please come. Don't delay your care. It's safe to come to the emergency room. Deliveries for the month were lower than budget by 11 at 132 in July. Surgical cases were 25 below budget at 357. That was driven by our joint cases, our cardiac cases, and our general surgery cases were all below budget. Our neuro cases were actually 3 above the budget in the month. Cath lab procedures were 44 above the month at 422. Those were driven largely by peripheral vascular procedures and cardiac procedures. Outpatient visits for the month, 99 above the budget at 7,268. It's good to see those numbers coming back. Emergency room visits, including the RSTU, came in at 6,064. But we had about 2,762 COVID related patients that came through the RSTU included in that number. Our regular ED visits were 3,302. Quick look at the Cath Lab Activity. Peripheral vascular really has maintained steady volumes for the most part throughout this COVID crisis. Peripheral vascular making up 48% of the volume in July. Cardiac volume's been slower to come back, making up 33% of the volume in July. Non-vascular interventional radiology coming in at 17%, and neurointerventional radiology just slightly lower than 2%. Looking at productivity, our productive FTEs for the month came in at 122.1 above budget at 1,359.8. We had 176.9 non-productive FTEs. That was actually 31 below budget, giving us total FTEs that were 91 above budget at 1,536.7. However, FTEs per occupied bed for the month, that's our productivity indicator, came in 0.19 below budget at 6.39. Moving into the financials, and as always, we'll start with our Governmental Accounting Standards Board presentation. Total patient revenue for the month came in at $13.7 million above budget at $181,068,000. However, our contractuals for the month were unfavorable. We had a very unfavorable payer mix. Those came in at 78.35%. We'd expected 77.22% for the month. And a quick look at the details of that. Really our contractuals for Medicare way up. Government payers made up 74% of the net revenue or gross revenue in the month. We'd expected 71.1%. Conversely, PPO came in at 21.7%, which was pretty significantly below 24.3%. So again, you see those total deductions at 12.622%. That equates to us really only keeping about $1 million of that $13.7 million gross revenue variance. So we end the month with net operating revenue, like I said, about $1 million above the budget at $39,482,000. Operating expenses for the month came in $2.7 million higher than budget at $42,448,000. The majority of that driven by labor costs. With our higher FTEs, our salaries and wages were about $2 million above the budget. Few things driving that, both the higher FTEs and it's really difficult to get in this environment agency staff to come in, for instance, traveler nurses. So we ended up having to backfill a lot of that work with overtime and double time in the month. So those were really the two major drivers of our salaries variance. Likewise, our benefits were about $500,000 higher than budget, driven by health and welfare claims, and we had higher employer taxes with those higher salaries. The other main driver for the month in that expense variance was our purchase services. We did incur more expenses for send-out tests for COVID. As we still struggle with supplies to do testing in-house, we're having to send more out than we expected in the budget. So we end the month with an operating loss of $2.966 million, about $1.7 million lower than budget. Non-operating income for the month came in $386,000 higher than budget. That includes a $309,000 unrealized gain in our investments. We also had positive variances for interest expense, investment income, and we have not incurred any bond issuance costs yet. So we ended up the month with a total bottom line of just under a $2.5 million loss for July. Looking at our Financial Accounting Standards Board presentation, and again, this is a presentation that shows how our financials would look based on some adjustments that Wall Street might make to our GASB presentation when they're looking at our financials. And after those adjustments, we end up with an operating loss from a FASB perspective of $3.6 million and non-operating income from a FASB perspective of $605,000. So we end the month with a net loss from a FASB perspective of just over $3 million. Whoop. Sorry. We'll take a quick run through our EBITDA format. This is the format we look at to kind of estimate the income cash income that the operation and non-operating activities are providing for the healthcare district. First thing we do is we pull our non-cash depreciation expense out of our operating expenses, and we come up with earnings before interest, taxes, depreciation, and amortization of a little bit over $1 million. And then we look at our non-operating activities before our interest expense, and we end up with non-operating income of about $2.3 million. giving us a total of about $3.35 million that the operating and non-operating activities for the healthcare district provided for our interest, our bond service, and other capital expenditures. So are there any questions on July? Okay.
All right. Thank you, Chris. Well, we're off to a pretty bad start, but I mean, that's a reflection of our time. So would you please continue, Kimberly, with the operations report.
All right, I will start in August. You're going to see some of the same trends as that we saw in July. So our gross revenue of $172.1 million for August was above budget by $5 million or 3%, but below the August of 2019 by $9.7 million or 5.3%. Inpatient gross revenue of $117.5 million was above budget by $10.7 million or 10%, but outpatient gross revenue of $54.6 million was below budget by $5.6 million or 9.4%. Looking at the key statistics, average length of stay of 5.75 was above the budget of 4.94 by 0.81 or 16.4%. And really, again, it's a combination of a number of factors, and we're still seeing a high number of the COVID patients in-house that we're staying longer. We're just seeing patients that are sicker, and it's also been difficult for us in terms of placement of patients back into congregate living systems too. So that's all contributing to the, again, higher length of stay. Our observation days were 11 or 6.8% above budget at 173. Average daily census of 165 was above the budget of 141 by 24 or 16.9%. Looking at our admissions trends, admissions were below budget by 44 or 5%. But then if you go to the next, you will see in terms of our patient days of 5,120 were above budget by 741 or 16.9%. And these patient days for the month were 83 or 1.6% even above August of 2019. Looking at our surgical trend, our total surgical cases in August of 348 were below budget by 41 or 10.5%. Our inpatient surgeries were 23 or 11.6% below budget at 175, and 69 or 28.3% below the August 2019 volume. And outpatient surgeries were 18 or 9.4% below budget at 173, but 27 or 18.5% above August of 2019. So breaking down the surgical activity, you can see that our joint replacement surgeries were below budget by 39 or 23.4%. We did have one physician who was out for part of August that contributed to this not meeting budget. We had cardiac surgical procedures were below budget by 8 or 61.5%. Our general surgical procedures were right on budget. And our neurosurgical procedures were above budget by 6 or 33.3%. Moving on to Cath Lab, our Cath Lab procedures for August of 309 were 49 or 13.7% below budget. And really, at this point, if remember, we had a new physician that was joining Dr. Bruce Lynn in IR. And so he just started during August that helped to contribute to this issue of not meeting budget. Inpatient Cath Lab procedures were below budget by 17 or 8% at 195, and outpatient Cath procedures were below budget by 32 or 21.9% at 114. So if you, next in terms of breaking down the Cath Lab activity, peripheral vascular procedures were below budget by 58 or 37.2%. And again, this is the bringing on a new partner and him just starting in IR. Non-vascular interventional radiology procedures were below budget by 8 or 9.8%. Our neurointerventional radiology procedures were above budget by 7. and also 3 above the budget of August 2019. And cardiac procedures were above budget by 10 or 8.4%. Moving on to deliveries, slower with deliveries for August were at 122, which was below the budget by 29 or 19.2%. Moving on to our non-ER outpatient trend, this continues to be slow to return. Our non-emergency outpatient visits of 6,773 were below budget by 459 or 6.3%. These visits were below the August 2019 by 17.3%. Our EKG visits were above budget by 126. Our lab visits were above budget by 48. However, our cardiac rehab visits were below budget by 203, and lymphedema clinic were below budget by 58, and x-rays were also below budget by 292. Looking at our emergency room visits, you can see that we're starting to grow in terms of the emergency room visits. They came in at 3,695, which were below budget by 177 or 4.6%. And they were below the same period last year by 557 or 13%. Looking at our rapid screening and treatment unit, our RSTU, where we do a great deal of respiratory screenings, we saw 1,951 visits, which were below budget by 171 or 8%. Then looking at our gross revenue recap, surgical cases were below budget by 41 or 10.5%, driving surgical services revenue down by $6.1 million or 17.8%. Our Cath Lab procedures were below budget by 49 or 13.7%, driving Cath Lab revenue down by $945,000 or 7.6%. Emergency room visits were below budget by 177 or 4.6%, driving emergency room revenue down by $508,000 or 4.9%. Our inpatient days were above budget by 741 or 16.9%, driving room and board revenue up by $5.6 million or 17.7%. And the higher level of inpatient activity also drove our ancillary services revenue above budget by $7.8 million or 10.4%. Now moving on to our payer mix. It is better than July's, but still there are some areas that still remain unfavorable. If you can see, our government-sponsored patient revenue made up 71.5% of total gross revenue, which is higher than the budget and prior year of 71.0%. HMO was 3.1% of gross revenue, which is above the budget of 2.6%, but consistent with prior year. Our PPO revenue was 22.9% of gross revenue, which is below the budget of 24.4% and lower than the prior year of 23.1%. And our private pay was 2.5% of gross revenue, which is above the budget of 2%, but slightly lower than prior year at 2.6%. So really seeing some increase in the Medi-Cal and private pay right now, which we are watching as we look at unemployment statistics too that's happening. All right, other operational statistics. Washington outpatient surgery center cases were below budget in August by 61 or 14.1% at 372. Our clinic visits of 2,599 were below budget by 74 or 2.8% for the month of August, and 25.4% below the August of 2019. We had saw Washington urgent care was below by 239, and Warm Springs Clinic below budget by 6. Danielson Clinic Newark was up by 39, and Nakamura Clinic was up by 137. Did I forget one? Let's go back to the FTEs. I think I missed one slide. Go back. Thank you. Sorry about that.
There we go. Right there.
Preliminary productive. All right. I turned the page. All right. Productive FTEs were above budget by 152.2 or 12.3% at 1,387.6. Our non-productive FTEs were below budget by 14.2 or 8.2% and 159.3. Total FTEs of 1,546.9 were above budget by 138 or 9.8%. And really the majority of our variance is driven by the increase in patient days that we've been seeing and some of the COVID FTEs some of the FTEs that we brought in terms of COVID that are COVID related. So if you look at our productive FTEs per adjusted occupied bed, they were at 5.73, which was higher than the budget of 5.59 or by 2.5%. However, our total FTEs per occupied bed, adjusted occupied bed, was at 6.39, which was very close to the budget of 6.38. It was off by 0.2%. All right. Go back to where I was key financial statistics. Days cash on hand for August ended at 185 days, a decrease of 1 day from last month. Our days of gross revenue and accounts receivable was at 61. And there were 889,035 in charity care applications pending or approved in August, which as you can see is up from the prior month, but somewhat aligned with the prior year. Lastly, going on to the summary of homeless patient activity, there were 201 homeless patient encounters in August of 2020. Estimated incremental cost of Senate Bill 1152 for the month of August is $283,000. Estimated total unreimbursed cost of homeless care for the month of August was $426,000. And estimated total unreimbursed cost of homeless care for fiscal year to date is approximately $714,000. So if you go to the next slide, you can see in terms of the breakdown, there was a significant increase in avoidable days, which drove up the estimated unreimbursed homeless cost in August of 2020. The red portion of the bar represents the monthly estimated incremental cost, where you can see the avoidable days, inpatient days are in there. And the yellow portion of the bar represents the monthly total estimated unreimbursed cost. So you can see sort of where some of the challenges have been. And that is the report for August. Any questions?
I have a quick question. You had mentioned the COVID patients from the, congregate living homes, SNFs and all. Are they not accepting patients back as soon as they could be? So we have to keep them longer?
Yes.
Or?
Sometimes there are challenges with placing patients, whether or not they came from a specific skilled nursing facility or not. If they need skilled nursing facility care, there are some, it may take longer to get them into a skilled nursing facility because there are those that may not be taking new patients. They may take back their transfers, but at times they may be not taking new patients, and even at times they may have a hold in even taking on their transfer back, depending on their situation too. So that has been something our case management team and along with Mary Boron and Stephanie Williams has been working on in terms of that's part of really having that open dialogue with the skilled nursing facilities as much as that we can, because it's important that we have places to place patients, but at times it can be very difficult.
Okay, thank you.
I had a question for Chris, Kimberly. Are you following what our other district hospitals are doing in terms of performance, financial performance in the recent months or like last month, or how are they doing? Or do you know?
Yeah, well, no, I do keep in contact with several of them, and they're struggling, some of them much worse than we are. We did very well with meeting guidelines for pulling in some of the federal grant money. It didn't go so well for some of the hospitals, particularly out in the Central Valley. Some of the larger hospitals there's one in particular down in Visalia that's really struggling for survival. And a lot of the smaller hospitals, a lot of the rural hospitals also likewise are really struggling. They just don't have the resources to absorb a lot of this additional cost and the lower volumes that they're seeing. So I'd say comparatively, we're doing pretty well, particularly, the way we ended up last fiscal year. But we're all struggling with the same thing.
Well,
I know
aside from the magic that you pulled with getting the government money, all that aside,
Yeah.
how do we compare then with the other hospitals in the Bay Area in terms of our volumes business?
Yeah. Everything I'm hearing is the similar story to what we have. ED volumes are down in the Bay Area and in the Valley. It's the surgical volumes, likewise, Cath Lab. It's all very similar to what we're experiencing here. People are, not wanting to come to the hospitals. So it's a very similar situation from the folks that I've talked to.
They're also seeing some of the ones that I've spoken with too are starting to see that shift in the payer mix too.
Yep.
In terms of more government sponsored, whether it's the Medicare patients that have either delayed care or now coming in for one reason or another, or they're starting to slowly see a little bit of a creep in terms of Medi-Cal, and also seeing more a little bit of a greater percentage of Medi-Cal patients. So I think those are the two that I know that when I've spoken with some of the hospitals, that's really the piece that's starting to struggle.
Okay. All right. Well, thank you. Thank you both. Are there any more items for the agenda today? Any board members want to talk about anything else? All right. Well, hearing none, we will continue. And now we'll go into the closed session. However, before doing so, I want to let the public know that they have a right to know what reportable action, if any, was taken by the board during the closed session. Normally, the board would make that announcement following the closed session. As we do not know how long the closed session will last, we do not want members of the public waiting indefinitely on the phone for the board's report. Therefore, we ask you to contact the district clerk tomorrow. She will be happy to respond to any inquiries about reportable board actions. Our minutes will continue to reflect any reportable actions taken. So thank you, and the board will now adjourn to a closed session.